Thank you for the opportunity to give an update. And I should say up front that I'm very much doing this on behalf of Rodney Russo, who was the student who really did all this work. So the PROOV IT study is looking at immune non-responders and testing a probiotic to see whether this is able to reduce inflammation in people who have been on treatment for a long time and have had suboptimal CD4 recovery. So some important background is just that, again, a study that Rodney led with Sharon in the immunodeficiency clinic here was comparing immune non-responders, INR, with clinical responders, that is people who also had a native CD4 count less than 350, but after 2 years have not had recovery above 350, and comparing immune parameters in those two groups. And what he saw, I won't go into the details, but what he saw was that the INRs were differentiated from clinical responders by having elevated CD8 T cell activation in blood, elevated CD4 activation, at least by DR expression, and elevated alpha 4 beta 7 expression. So the alpha 4 beta 7 expression made us interested, given that we know the gut's very important in the context of HIV. It takes a long time to reconstitute CD4 cells in the gut, and there's differential effects on different subsets, with Th17 and Th22s being particularly affected. So in primates, and again, I'm not going to have time to show you that original data, but Nikki Klatt and her colleagues had a JCI paper almost 10 years ago now, showing that if you gave a specific probiotic, this VSL3, that enhanced CD4 recovery in the gut, and it actually enhanced Th17 function in the gut if given early in SIV infection. And so those two things fed into this PROOV IT study. And actually, here we're using, as you see, it's the de Simone formulation. Again, there's a whole bunch of politics with VSL3 that I won't get into, but Prof. de Simone, who's the guy who formulated that VSL3, actually had a disagreement with his company, so he went off and made his own probiotic with the same formula called Visbiome. So our trial is actually using Visbiome, or this Damone formulation probiotic. And the idea was that therapeutic manipulation of the bowel flora using this probiotic would reduce inflammation and restore gut immune function in immune non-responder men specifically. At the advice of the CTN, we limited our enrollment in the trial to men. And so we aimed to look at the effect specifically on T cell function, T cell inflammation in blood, CD8 T cell as our first endpoint, using this Visbiome or de Simone product. And again, a mix of lactobacilli, bifidobacterium, and Streptococcus thermophilus. So this is made sort of a pharmaceutical grade probiotic. So you very consistently get live bacteria tested by the company throughout the trial. And it was 2 sachets of 450 billion bacteria was our intervention. Enrolled, same definition of immune non-responders, individuals who had a well-suppressed viral load for at least 2 years, but despite that had not recovered a CD4 count above 350. And I originally aimed to, we cut our enrollment a little short due to our initial results, but we aimed to enroll 36 individuals in a 2-to-1 randomization, so 24 getting probiotic and 12 placebo. Primary endpoint was CD8 T cell activation in blood at week 48 after 1 year, and secondary endpoints were CD4 T cell activation based on Rodney's preliminary data that you saw. Of course, adverse events, adherence, and product safety. Small bowel permeability, again, this is called the Lachman assay, something that people may be familiar with. People go to bed, they drink a Kool-Aid drink that has in it a mixture of lactulose and mannitol. Lactulose is not supposed to get absorbed by the gut, whereas mannitol is. So normally you would pee out a lot of mannitol the next morning and not much lactulose. But if you have a leaky small bowel, you absorb lactulose. So you have a higher Lachman ratio in the urine. So essentially you collect first void urine in the morning, and you're looking at how much lactulose you have in relation to mannitol as a direct marker of small bowel permeability. This is quite a well-validated test used in GI research. We also looked at our traditional biomarkers of adverse outcomes in people living with HIV on treatment, so CD4-CD8 ratio, inflammatory biomarkers, coagulation biomarkers, etc. And in a subset willing to have gut biopsies, we collected gut biopsies to look at T-cell immunology in the gut. So just there's the flow. You'll see that in the end we enrolled 29 people, and in collaboration with our biostats core at the CTN, because enrollment was slow, given our preliminary results, we did not actually go ahead and enroll the full 36. I'm not going to get too much into the participant characteristics at baseline, but they're all there if anybody wants to have a peek in the paper. And one thing I just wanted to say, we were very interested. We collected quite detailed diet information, and so Rodney, with a summer student FART in the lab, calculated with there's a team down in the US who invented this dietary inflammatory index, and in people not living with HIV, you can look, you can actually calculate this inflammatory index, and it's had in a few papers quite tight correlation with inflammatory biomarkers in blood. So we actually looked at whether that diet inflammatory index at baseline at enrollment in the study correlated with inflammatory biomarkers in our INR participants. So we did see the Lachman ratio correlated very nicely with, given the small numbers, with plasma soluble CD14, indicating that the latter, that plasma soluble CD14, probably is related to gut leakiness. But we did not see any correlation of any of these parameters actually with the diet inflammatory index in these INR participants. So the conclusion was, we think likely that any diet inflammation link that may well exist, and actually there was quite a wide range of DII score within this cohort. We think it's probably trumped by the pro-inflammatory effects of chronic HIV infection, and we know that in INR individuals we already have quite high inflammation compared to the general population. In terms of the primary study endpoint, what you see here is the change in T-cell activation in CD8 T cells on the left, and then DR expression on CD4 cells in blood on the right, and the change in the placebo, those the hollow circles, and the Visbiome group, or the Dissimone probiotic group, that's the solid blue circles. And you see that our primary endpoint, CD8 activation, there was a slight increase in the Visbiome group and a slight decrease in the placebo group. No statistical difference between the two groups, but a tendency to more reduction in inflammation in the placebo group, and a significant increased reduction in CD4 DR expression in the group getting a placebo, as opposed to the group getting the Visbiome. So again, certainly no suggestion of decreased inflammation in the Visbiome group. And we looked at a number of plasma markers and the Lachman ratio. In no case did we see a decrease in inflammation in the Visbiome, the probiotic group. There was a slight increase actually in interferon gamma in the probiotic group that went away when you excluded one outlier, and no difference in the other parameters. Certainly very well tolerated. We had absolutely no signal of increased GI symptoms, and we had quite detailed GI symptoms that we were collecting in the probiotic group. I won't get into it too much, but we did in that subset. We're just putting together the paper now with Rodney in terms of the gut immunology. Again, no significant impact of the probiotic on gut immunology whatsoever. So in summary, probiotic supplementation with this pharmaceutical-grade probiotic that had shown some promise in a primate model did not reduce peripheral CD8 T-cell activation in immune non-responders. In terms of secondary endpoints, no decrease in plasma markers of immune activation, actually an increase in CD4 T-cell activation in the probiotic group, no change in intestinal permeability, and no substantive change in gut T-cell subsets, including Th17 and Th22 subsets in the gut. So most important person to thank would be Rodney. Other key co-investigators on the team were Ron Rosnes and Robert Reinhardt, so thank you very much to them for their help. Lots of other people in the lab, our clinical leads who were Colin Kovacs and Sharon Walmsley. People who were collecting the gut biopsies for us were Gabe Kendall and Louis Liu, and many other people in our team. So thank you very much to everybody, and of course the CTN team, including particularly the biostats core, Dr. Singer, and Leah Sadowski in the UHN Biostats unit. So thank you.